Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back to the Functional Code. We're on episode 9, the body series. Today we're going to be going over all aspects of the knee. I'm Dr. Jace.
I'm Dr. Addy, and we are excited to bring to you guys today everything regarding the knee. Not only that, but we have some really cool stories and topics regarding the knee. We're going to get into the evolution of this knee. It's a pretty simple joint, but there are a lot of things that can impact the knee and other joints that can put strain and tension on this knee. We're going to talk the common conditions that we see when we face knee pain, things that you guys can do at home, obviously, to manage this. I'm excited to get into this. We're going to talk about famous NHL player Connor McDavid. What happened to his knee, which when we tell you this, you're going to be freaking blown away at how this gentleman did not get surgery after receiving one of the worst injuries to a knee I think I've ever seen.
Same.
And the doc's going to do a phenomenal job of going over what that case looked like and how it was managed. And by a chiropractor, by the way, I had to throw in a plug by that. But no, yeah. It blew my mind to hear about that. So starting off, Doc, when we talk about the knee, I think people, believe it or not, probably think that when they have knee pain, it's directly due to something to deal with the knee. But the knee itself, what kind of a joint is it? How does it move? And how did we kind of adapt to put so much dependence on this little joint?
So this knee, or our knees, they're hinge joints, which pretty much bend and straighten. However, there is also availability for a little bit of rotation, which changes a lot of the dynamics. Now, when we look at past fossils of Homo sapiens, there's different structures that we've noticed have changed. We notice with monkeys, chimpanzees, apes, gorillas, they walk kind of side to side fashion. They don't allow very much movement of the knee. They are able to be powerful and explode off and move and use their arms with their feet to explode and going forward or backwards, if we will. But as we evolved and adapted, there's one small change that has a huge, profound impact on bending our knee, going from standing to seating much easier, and that's a muscle called the Popliteus, which goes on the back of this shin bone, the tibia, and then it translates over across the knee joint on the femur off the condyle. And that one key distinction, when we evolved, that small muscle went from the tibial bone to the fibula. So it just helped connect and stabilize the bottom two bones in the lower leg. And as we grew and adapted, and more than likely this is where some of the adaptation came from, as we focused on running for periods of time, focused on hunting, crawling, scavenging, we needed to be able to move our knees, thus bend and straighten much easier. Now, this muscle controls locking and unlocking the knee in combination with a bunch of other muscular structures, but that one key adaptation helped propel us forward, and I think also accelerated the aspect of turning us into an athlete, turned us into a species that were able to go for longer periods of time. We were evolved to become endurance species.
Yes.
And I think that was a huge adaptation which helped our evolution for hunting prey, for going on scavenges in groups for hours on end. I think that was the one key adaptation. There's other adaptations that have occurred to build up the knee joint so we can restabilize it, and that's where the condyles from the bottom portion of the femur or the thigh bone and the tibial plateau or your shin bone, that real estate, that joint expanded wider, thus also allowing us to have more pressure against gravity for longer periods of time. So there's a few things with that. Also over time, it created more of a diminished Q angle, which is, and we're going to talk into this a little bit, which is the angle between the hip joint and the knee. For females that have naturally wider hips, they have a higher Q angle to where the knees typically come inwards more versus males that are not as much. So that's another aspect too. But I think as we keep evolving and adapting moving forward, this joint can change. It's just going to take thousands of years for the structures to evolve depending on the demand placed on it.
I didn't realize the knee was the largest joint in the body.
Yeah, that's...
Yeah, I had no idea. I found that out when I was looking that up. I think I like that you brought this up, because when I was treating patients that had knee issues that weren't responding, I would test the popliteal tissue and I'd find it to be very weak. And I think that's a very overlooked muscle.
Yes.
I think it's small, but it's, like you said, it's crucial. It's crucial for stability of that knee. And
Absolutely.
among other things that I think can be contributors to knee pain, but directly correlated to the knee area, I think that's one that I tend to look at pretty quickly when I find patients not responding to care.
Same here. And then you look at the other structures involved too with it. So as we're going to the structures of the knee, when we're looking at not only the bone structures, we want to look at the tibia or your shin bone. We want to look at how that correlates to the bone outside the fibula. Not only that, how is the femur laid down onto that structure? Like, there's other problems that can come from this tibial tuberosity, which is this small bony aspect right below the knee. How is the kneecap translating and moving on top of the knee as you flex and straighten your knee? And then how are the structures of the ligaments stabilized and supporting? We're going to get into some of this as the podcast goes through. So there's ACL, PCL, MCL, LCL. Those structures are meant to stabilize the knee. And then a lot of the muscles, which some of them come from either the hips or quads or your thigh muscles. Some of them attach to the knee, some of them cross the joint and attach right below, especially the sartorius, which goes from your front hip bone around the inside and attaches below the knee. And then there's also tissues that go from the lower leg and work itself up, especially the gastrocnemius, which is your calf muscle, that thick calf muscle on the superficial aspect that crosses the joint and attaches also to the femur as well. But how everything moves and gels together was for a specific purpose. It was how can we best stabilize and support the structure in a walking, running, powerful combination of movements. So when we look at this, not only from the ligaments and tendons, but we also want to look at from the muscles overlying it, and where are some of the common problems coming from with the knee. And that you might have to look above and below the area, which we'll get to in a little bit, especially with rehab or just exercising and building up the knees.
Doc, I know this is a crucial part of the knee with patients who have an injury, but I think what most people don't realize is just how important the cartilage or meniscus is. So what specifically does the meniscus and or cartilage do for the knee?
With the meniscus, there's cushion, but it's not in a normal disc-like shape as you would think of the discs of the spine. This oftentimes with more pressure on the inside portion, especially with females having a larger Q angle, has to be able to support our whole body weight against gravity and with certain movements. So that's going to involve thicker meniscus tissues on the inside portion of the knee and not as much on the outside. But yes, it's for shock absorption and also to have the femur glide on top of the tibia, and then same thing to rock backwards in combination with how well the patella or your kneecap can move on top of everything as well.
And I'm curious, that's interesting you bring that up, the fact that obviously we have that much larger medial meniscus, but it must make sense because what we find obviously over time is that area is what's worn out much quicker in patients. So my guess is it's probably evolved to needing to be thicker because of just the anatomy of us having to have more strain on that inside knee joint anyway.
Absolutely.
Is my guess. But that's interesting that you bring that up.
It's good theory, yeah.
And speaking of just external strain on the knee, if again, I find that the knee, and most oftentimes I really look elsewhere before I actually agree with the patient that the knee is what's causing their knee pain, unless they directly fell onto it. What you'll find, it's a hinge joint, so like Doc said, it's very simple. There's not much that can go wrong unless you look below and above it, two very mobile joints, the ankle and the hip. So we have the hip, which is a ball and socket joint, and then the ankle, again, a very mobile joint. So most of the time when I hear a patient explain they have knee pain, I want to assess the hip and the ankle at the same time because more often than not, they've either sustained an injury to one or both, or you'll find weakness or breakdown in that area because, again, what you'll find is when you don't have proper mobility to a very mobile joint, it's going to put or adverse strain on the joint either above and below it. And then if you'll find as the kinetic chain goes, and just basically the chain of joints up your body, it goes from mobile to not very mobile. So you have the ankle, which is mobile, to the knee, which is non-mobile, to the hip, which is mobile, to the SI joint, which is not very mobile. And so when we have a breakdown in the very mobile joints, we're going to see strain on the non-mobile joints. And so the knee takes a hit, the SI joint, or what many of you think is your hip joint back here, it's actually called your SI joint, can take a hit. And that's when you need to start figuring out where is the weakness in the mobile joints before you start seeing adverse effect on the non-mobile joints. So just wanted to obviously touch on that.
That was beautiful. So, Doc, when you see like people have pain or discomfort on the inside of the joint, where does your mind go?
So when we talk medial joint line tenderness is how we would phrase it. We already start thinking inflammation because there's pain with touch. And what usually comes with inflammation, especially if a patient's above a certain age, is going to be degenerative changes, swelling, those kinds of things. I'm already thinking if the patient is the age group that I'm thinking, I'm worried that we have degenerative changes going on, osteoarthritis. That one is almost textbook, where patients of age, they're starting to get medial joint line tenderness. They maybe even are having intermittent swelling, pain to the touch. That's going to be something I'm going to hit on right away. Now, younger patient, maybe they just are active, and I'm thinking, okay, it's not arthritis. It might be just improper gait, where they're not able to move, run, or walk, and we might have a breakdown in just anatomical variant of strength or structure. But if they did sustain an injury, more than likely that medial meniscus, like we talked about, good chance if it's not getting better, there might have been an injury there. And why it's not getting better, a lot of you need to realize this, is cartilage is not very vascular. So when there is an injury sustained to the meniscus, there is not a good proper blood flow to that area, so very rarely it will actually ever heal by itself. So what you're going to be stuck with is the inability to heal that area. So if you can grow and stabilize and create as much strength as you can around that knee so that it can properly stabilize that area, that's going to be the best way to avoid further damaging to that meniscus. But in times it might not improve and you might actually need to get it cut out, which again, it's not something that I was excited for, and we'll get to the meniscus further down, but those I would say are the two big things that I would take on as far as medial knee pain.
Absolutely.
For sure.
Yeah, and just to add on to what Doc said, because my mind goes to the same thing as well. It depends on person, conditions. Is it acute, or is there a traumatic blow to the area, or is it over time? And even individuals of like our cheerleaders or individuals that are in gymnastics that are very flexible, that move their bodies in many areas, they often have discomfort in areas that are supposed to be stabilized, especially with the knees. So how well can we strengthen and stabilize those areas of not only tissues from the hip going on the inside of the leg, but also the tissues on the outside? Because as we walk from step to step, we have to rely on these tissues on the outside to support and stabilize not only our leg, but if we look at the same thing with our torso and body, as we walk, how well can those structures stabilize so it doesn't give out and cause more hypermobility or more movement in the joints that are supposed to be mobile?
Yes.
So, and that's just looking top down, but also the same thing of your foot. And we're going to get into some gait stuff here, but how well can the tissues on the inside and outside support the knee? And do you have, if you have your foot, is it more narrow or do you have a wider base? And how well can that support the system coming up from there? So I guess, Doc, because I know you have an awesome specialty and a lot of experience with people in gait, how does that affect, like if you have a poor gait, how does that affect the knee structure and the whole body itself? And what are some things that you look at?
Perfect. Yeah. Well, I think most people, the way that I can explain it in a way that is going to be relatable quickly is if you have flat feet. So for those of you, which is most likely a lot of you, if you have flat feet, what you'll find is flat feet, otherwise known as overpronation, what's going to happen is when we look at the ankle, you want to make sure that all the structures are in line in sitting on top of one another without any deviation. So when someone has flat feet, it's what's called overpronated. So what you find as pronation happens, the arch will start to collapse and the ankle becomes pronated. And this is going to put heavy strain on the ankle now. What you're going to find is that's going to actually derive strain up to the knee. So what you find is with overpronation, you have a tendency to now pivot at the first metatarsal. And what that means is you should already have a healthy arch, and your ability to dorsiflex and have a good arch should already be sustained in someone who has a healthy foot. But if you do not have that, you're going to start to compensate. So with someone who is starting to have pronation, flatter foot, they'll actually start to find is when they start to toe off, they should be able to dorsiflex that toe and push off very well. But if you cannot do that, then you're going to pivot all your weight off of the first metatarsal. And why that's a problem is you'll develop what's called an abductory twist. And so what that means is that tiny little change in your gait is going to push and cause your entire leg to externally rotate after you toe off. So now, one tiny change in your foot structure now threw off your entire leg, and you're going to be adding more external rotation as you walk so that when you come down onto your foot, you pivot off the first metatarsal. But what I want you to take home is already the tiniest change in that foot structure is going to play a huge role up the chain, and it does it instantaneously without you even probably knowing. And over time, if you continue to have an abductory twist, it's going to cause more strain on the lateral tissues of the hip, it's going to cause tissue strain on the knee, and it's going to continue to cause worsening pain in the feet. And what you'll find, and we've even found this within the last, I feel like a couple months, we've helped this with patients who do not have the ability to toe off properly and have an abductory twist. When we start retraining their gait, give them proper foot structure, their pain goes away quickly, very quickly. And again, that's just something that we're trying to drive home is it's these little changes in other parts of the bodies that can have such a crucial impact on other joints or other parts of the body. So when you look at knee pain, you got to look at the foot and you got to look at the hip.
Absolutely. And we're going to dive into this more when we get to the feet specifically and how that goes up the chain. We're going to reiterate a few of these things too, but just to pay attention to the areas top down and also bottom up, how that can affect not only the whole structure, but also specifically the knee joint. So when we add on time against gravity, when we add on flat feet and a lot of pressure on the inside of the knee, or problems with the hip, and it puts more pressure on the inside of the knee, that can lead to breakdown of the knee joint, which can lead to osteoarthritis. So what have you seen with osteoarthritis? How does it present in the knee?
Yeah, with osteoarthritis, patients are going to have 3 or 4 main symptoms. The first is going to be just joint pain. So you're going to state that the pain is diffuse. It's maybe around the knee. More often than not, it's medial first. That's usually the area that it'll wear out more quickly. With that, you might get swelling. It will probably be very stiff in the morning when you awaken. Through walking and over time during the day, the stiffness will go away. It'll feel a little better. In worsening cases of arthritis, you might hear clicking, cracking, popping, cavitation, crepitus is a lot of those noises. And it might even be to the point where it's unstable, or it's degenerated so much that you lose motion. You're not able to flex and extend fully. So with osteoarthritis, when we take a look at it clinically, the quickest way is for us to view it on an x-ray. And the 3 things or 4 things that we'll find is there's narrowing of the knee joint itself, and so we can see the spaces starting to close off. We might see bone spur formation. Another name for that is just osteofication or bone spur formation. We might see what's called calcium deposits, or just these bony deposits around the knee or even in the soft tissue. A lot of people don't realize what a Baker's cyst is, but it can be a reaction to the instability and degenerative change in someone with arthritis, where you have swelling behind the knee. That's something we may see. And lastly, there just might be bone marrow edema or subchondral cysts, where not only is it degenerating in the synovial joint, but it's degenerating in actually the bony matrix of your tibia and femur. We're starting to see formation of fat and just breakdown of the bone as well, which once we get to those stages, we know we need some intervention, otherwise it's going to be very painful.
Absolutely. And there's a few ways that we can go about this. And in terms of treating the osteoarthritis of the knee, one of the best ways is exercise. There's other ways that you can go about it in terms of bracing. It's how well you can take pressure off the inside of the portion of the knee and translate it to the outside, or vice versa. Like, let's say you're a soccer player that you've played for 20 plus years, and you have a lot more breakdown of the body, breakdown of the knee on the outside portion. It can be very similar to redistribute pressure to the inside, or cause the need to go into more internal, external rotation to build up some of those deeper structures. So what we found with a few of these studies, first off, was Hochberg et al. In 2012, noticed with an exercise program, it has improved not only the pain, tenderness, increased the range of motion. This is over a 12-month period, but it helped prolong the quality of the joint, which not necessarily can combat the bone spurs that were in those patients, but it can help improve the quality of how well you can function pain-free as well.
And you better believe that the therapy we do here not only involves the knee, but again, those structures that we talked about. We are looking right away at how they're walking, making sure that we address those structures too. And if you find yourself in therapy for knee pain and you're stuck doing just the banded knee curls or things that aren't addressing other structures, I would just you don't have to quit. And what I would have you do is just ask questions and say, hey, do you think there's maybe any other structures that could be contributing to this? And is there other things that I could be doing aside from just focusing on the knee that would help? We're going to say, yes, there is, but just please ask your provider to see what they think. And if you feel that you should also be addressing other joints, if you agree with us from listening to this, then we would recommend that you do, because what we find is more often than not, it's going to be way more helpful when you address more structures than just one.
Oh God, yeah.
Yeah.
The body communicates as a whole and in general. And with the knee joint, if you're not addressing tissues on the inside and outside, especially from the hip down and also ankles up, you're doing yourself a huge disfavor, and you're not going to reach the potential that you could have if you do rehab on these other structures and tissues. But yeah.
And if it comes to the point where you need surgery, by all means, that's where, you know, the surgeon and you are going to have a conversation. There will come a time, and I have done this many times in the past. When I first started in practice, I would say 80% of my patients were either those who are dealing with feet pain or knee pain. That's what I saw, neuropathy or knees. And there were definitely times where I referred to the surgeon. So this is going to be a time where surgery is something that I'm definitely for if needed. But please, what I would want to make sure that you know, and we might even put some pictures up for you, but you need to understand what the difference between the stages of degeneration are for the knee and bone on bone.
Yes.
Because what you'll hear oftentimes or not is, oh, it was bone on bone, so we had to do surgery. Well, I can tell you from experience, I don't know how many patients have come in to me needing a second opinion, and they were wondering, Doc, do I really need surgery, or can I do this without? I take a picture of their knee. They are not bone on bone, and far from it. So I just want to make sure that you guys understand there are times where words will be used to sway you in certain directions of treatment, and please just do your own research, be your own advocate so that you can understand. Get your eyes on the x-ray, have them explain to you why they think it's bone on bone, and then if not, if you still don't feel as comfortable, get a second opinion before you do something, you know, invasive like surgery. What you'll find, knee surgery, it's very effective for those who have what's called stage 4. Stages are broken down 1 through 4. I would quickly explain the stages as stage 1, you have a pretty good amount of space. 2 is it's lessened. 3, we're getting pretty close. 4 is it's now touching and we're getting fusion of that area. 4 is when I absolutely say, okay, I'm sorry, there's really not a lot that we can do to help manage this. Not to say we're not going to give it a try. PT could absolutely make a difference. It can maybe reduce pain and improve motion, but if you go about conservative care and you still don't find change, I have no problem recommending replacement. Again, the only problem that I have is knee replacement is done so much because, again, it's a common joint that's wore out. And I don't want to scare you away from getting surgery, but there is a study that was done by the UK Bone and Joint, and it was done to show that 1 in 200 patients, so this is, again, it's a small percentage, 0.005, 1 in 200 patients die after 90, at least after 90 days after getting knee replacement surgery.
That's
and
huge.
It's scary. It's scary to think because when I compare it to, let's say, COVID, where the latest adjusted stats on deaths was 0.0005, which means it was less of a mortality rate than those getting knee surgery, then yeah, I'm a little concerned. Why I'm concerned is because the CDC wasn't knocking down all of the operating room doors and trying to stop people from getting knee surgery, just as though the world was shut down off of COVID mortality rate.
1 in 200. Like, just if you can even fathom just even that statistic alone should give you a lot more insight into, is this surgery needed?
Yep.
Multiple opinions really, really matter.
The biggest factors that they're going to look at is your health, right? It takes a lot of effort on your body to go through a surgery like that. And so they want to make sure that you're in good health. Most of the time, those getting knee replacement surgery are over the age of 65. So it's just something to think about. Again, I am for surgery, and I have referred patients for surgery if needed. But what I'm seeing and what I'm predicting is probably happening is a lot of patients are getting surgery that don't need it. They're not bone on bone. They probably have a few more years to try to prevent surgery, and they're just quick to go under the knife. And the more people that have that invasive surgery, the higher chance, obviously, the population has to having mortality. So that's the research on that. Take that information how you will. I'm not here to slander anyone. I just need people to know the facts, and so that they can make their own decisions. So,
and we're at a point right now to where if you yourself have knee problems, like let's say you're on stage 2, 3, we're at a point right now to where we can increase the meniscus or joint space 1 to 2 millimeters at best, which can prolong the chance of you having surgery, one, or just delay it for years on out. And a lot of that will come via rehab of rotational work of the knee. Because if we go back to what Doc was saying with the gait, if you have tibial torsion with a flat foot and it's putting way more pressure on the inside portion of the knee, if you can strengthen the arch of your foot, create more rotational work, the brain, and untwist to have less pressure on the inside of the knee and redistribute that to the outside portion of the knee, that will buy you enough space, ease up a lot of tension, discomfort, and swelling on the inside.
It's a game changer.
Yeah.
Yeah.
Just even that itself.
And really the last thing that I know a lot of patients are doing out there before surgery, and it's something that I've done a lot, is stem cell therapy. This is an area of the body that I'm very comfortable talking about stem cells. There's other areas that still need a lot of research, but by and large, the most amount of research done for stem cells have been on knee osteoarthritis. That's been the condition and the area. And what they found is whether you're doing bone marrow, adipose, or umbilical, you're going to see good changes, especially when it comes to knee osteoarthritis. Before I get too deep into stem cell research, because I think we're going to leave that to a later podcast, but there are many ways to get what are called mesenchymal stem cells, and it can get from your bone marrow, from your fat. It can be from a donated tissue source from like an umbilical cord. There's literally 15 to 20 other areas you can get mesenchymal stem cells. You can even get it from colostrum, from milk from a mother.
Fascinating.
And oddly enough, exosomes, which are the secretions of stem cells, they have a very small half-life. The actual longest half-life from a mesenchymal cell source is from babies' breast milk. So it just shows that is such a long, outlived, crucial cell, and there's a good chance that why bodybuilders are buying that from mothers to boost themselves is such a hot commodity right now. But I don't know why I threw that in there. I thought that was funny though.
Sorry, that makes sense.
So when it comes to mesenchymal stem cells, what we have found is it can absolutely improve pain and increase outcomes, especially after a year or two. It can even prevent surgery. Prevent or delay surgery. Not always prevent, but it can at least delay surgery. I would say in my experience with all of the patients that I've seen, I think I saw close to 500 knees in maybe a year or two.
Wow.
And in that time, I would say the best outcomes were females between the ages of 45 and 65, and they were at least stage 2 to stage 3. That was the ideal candidate. Those got at least 90% or more and saw improvement. Now, just on average, I would say probably 60 to 80% of those who do not have stage 4 osteoarthritis, but anything under that, would see result with stem cell. So that's my best range that I can say off of what I've read and the experience that I've had. Is it something that you should do right away? No, because it's expensive. And I would probably state that you'd get pretty decent results with manipulation, mobilization, PT, lasers, other things first before jumping into stem cells. But some of the changes have been incredible. And what you'll find is it'll even have the ability to repair cartilaginous lesions. It can do a lot of other things that we used to never think was possible. And there are times where we even get space back. Pretty drastic change.
Crazy.
But it's not all the time, right? It's case dependent, and it's tough to make those claims based off of what we're seeing in the population right now. We need to do a better job of understanding who has the best chance of getting those outcomes so that we can educate appropriately. And I've had patients that were in their 80s wanting me to do stem cells on their really, really bad knees, and I just couldn't do it. many arguments with these patients, and I said, this is not going to help you. In my experience, it was not going to, it is. And if you're out there and you're dreading surgery, I get it. You don't want to do surgery, but don't go and waste all of your money on these things that you think are going to get your life back. More often than not, you were sold something that you should have gotten better education on. So in those times when you are last ditch effort to get better, I'm telling you, surgery's probably the best thing we got out there right now.
Now, Doc, I know other patients and people are probably thinking, okay, so stem cells, I know I've heard PRP in previous other podcasts that we've had. I guess, what's the difference between platelet-rich plasma and also mesenchymal stem cells? Are they the same thing? Are they different? Where are the studies with that?
Yeah, absolutely. So PRP and stem cells definitely are together underneath the umbrella of regenerative medicine. And a lot of the times they're used together.
Okay.
And what you'll find is, if you look into the research, more often than not, patients do better using those two together. So a lot of the times with protocols, they did a few rounds of PRP before the stem cell was injected or transplanted. And that protocol is pretty common right now. You'll find a lot of clinics doing PRP first before they do stem cells. We still are trying to understand the theory and the research behind it all, but it makes sense when you think about it physiologically, since platelets are the first to arrive at an injury.
Smart.
So when you look at like weeks of healing, the first few phases of healing are done by your platelets. It's not until maybe step 4 or 5 where then stem cells are then recruited. So what you find is, just in theory, you want to do platelet-rich plasma first, and I would recommend you try PRP first to see if you got improvements. Again, you find PRP is, I wouldn't say safer, because it's not that mesenchymal stem cell therapy isn't safe, but it is autologous. It's your own plasma, so already safe. From an umbilical stem cell source, that's going to be donated. It's not going to be your own. If you do your own fat or bone marrow stem cells, then that's a different story. But I tend to have found umbilical stem cells have been more favorable in my experience. But when it comes to PRP, definitely try that first. You should notice a difference. If it's far enough into degenerative change or severity of the knee, you'll notice the need of stem cells becomes more of a conversation. With the use of both of those, though, a lot of the similar cytokine profile and growth factors that come from the umbilical cord and plasma are very similar. You'll notice in PRP, you do have your own stem cells already in the collection of that serum. You're going to have your own exosomes in there, but it's just not going to be a lot compared to, you take a fresh umbilical cord, inside of it is this cushioning jelly fluid called Wharton's jelly. We want to talk about the amount of stem cells in that compared to PRP is 10 to even 20 times larger. So it's not that you don't have that, it's just the concentration is a lot less comparative PRP to stem cells. So really what I think I want everyone to know is those should be used in conjunction, because outcomes are going to be better. And if you're just going to do one injection of stem cell and nothing else, you're already setting yourself up to failure, because what I did on top of that was many other things that we do already in the clinic. It's making sure you're strengthening that knee so that there's less stress on the tissues that were damaged. Why I did the stem cell treatment in the first place. I want to make sure that, obviously, if you are heavier set, you're trying to lose weight, so it's not adding extra, pressure to the knee joint. Or if, for example, you are not walking correctly, and like we had talked about with the foot and the ankle, there's reasons to why you got to where you got to, and it wasn't because you needed surgery or you needed stem cells. No, it got to that point because of the habits and patterns that you were being compensating for. And that's really what I want people to know, because too often or not, they think they're at a place where, well, whatever life happened, I just need to go and get something done and I'll be better. That's not the way to look at it. You're going to spend a lot more money thinking like that, and you're going to get taken when you should instead think of it from a preventative standpoint of how can I best keep this pain away from ever even occurring. And that's going to be from proper assessment, making sure that you delete the bad habits of how you're moving, how you're walking, if you're overweight, if you're not exercising, those kinds of things.
That's a really good point. I'm learning something new myself too, because like between the platelets coming in first with the injury, then stem cells, and looking at from that approach for PRP, then stem cells, that I never thought of at that point. And then that last point that you touched on, change of the habits, the problem is just not going to resolve itself. I think that's something that we're going to say over and over again, but those are perfect and key points that we all need reminders on and to pay attention to. So yeah, really well stated.
And I love stem cells. I've gotten so many. I've gotten them in my knees, I've gotten them in my shoulders, I've gotten them intravenously. I think they have a phenomenal application. We're still trying to understand how to best utilize them. I do not want to deter anyone from doing them. I do love them. What I would deter you from is the cure-all pitch that stem cells can have, which is, yeah, they'll take care of anything. Anything you got, man, give me your money and we'll stick them in there and you're gonna see results. Guarantees too. I never, ever guaranteed anything to my patients. I said, what this is going to be is an experiment. You're going to sign a piece of paper knowing that. And I know I have seen outcomes experience-wise. I've seen it can help you. But do I know it's going to help you? I don't. And so that's how it should be pitched to you. If it's pitched any other way, I'm sorry, but I think you should find someone else. So
well stated.
Yeah.
Knowing who to follow and who not to follow or listen to. That's where multiple opinions comes into play quite well with that. So yeah, Dave.
So Doc, moving on to maybe more traumatic injuries or just things that people maybe have heard through time, which is the more common ligament that gets damaged from a sporting injury or just a pivot injury is going to be the ACL. So when a patient injures their ACL, you want to just maybe talk on quick the anatomy of what that looks like, and then what are some key common things that we know there's a good chance the ACL was injured and how they present?
So when we're looking at an ACL injury, it comes from most of the time a quick pivot. Oftentimes when the knee goes inwards and our body wants to go to the opposite direction. That can often bring with it not only a tear to the ACL, but it also can lead to a tear of the MCL, the meniscus. There's a lot of other structures that can be involved. However, with the ACL, anterior cruciate ligament, that's where it goes from the top portion on the inside portion of the knee, more in the middle, to wrap around and connect to the bottom part of the tibia. Now with this, it helps stabilize the middle structure of the knee. So if you have wider hips or a larger Q angle between, which is an angle between the hips and knee, if that is wider and if you have a tendency to have your knees go inwards, especially females, there's already going to be a lot of pressure on that ligament to where sometimes if you're just running or pivot or just running trying to stop without any contact, it can give out as well. But more times than not, it's pivot movements. It can be from most any sports, whether it's a complete tear or partial. That's where it'll depend on what treatment's best for you. And it's more common in females than males due to females having wider hips and larger Q angle, and often with younger athletes too, with less muscle mass and stabilization of tissues on the inside, outside the knee, and also tissues coming up from the ankles. But
so Doc, I kind of want to touch on this because I know people have dealt with this if you're a parent and your kids, or if you were obviously in sports yourself. There's been a lot of change over the years on the concept of an ACL tear in sports, and you just maybe want to touch on that and just do athletes who have had this injury need surgery, and is there even a way to avoid surgery with exercise? Is that something that can be done?
I believe so, yes, but it depends on the compliance. And then also there's a few other factors. Is it just the ACL or is there other structures involved?
Yeah.
So like if you're younger, if you are in your prime, if you're a professional athlete, I would probably get multiple opinions because I think there is benefit from having surgery, and when they do surgery, they're often taking a tendon from other area of the body, whether it's the forearm or calf, and put that in place of the ligament. Now, it's kind of fascinating enough, when you do have the surgery and they look at MRIs, when they put, whether it's a cadaver or part of your tendon in place of that ligament, over time, 12 months later, when they do rescan, that tendon turned into a ligament based on the load it was presented with. So that just tells us that the body is going to adapt to forces over time depending on what structures are involved. So when you look at the question of is surgery viable for the patient, the person, if it's a complete tear, I would probably lean towards that's something that I would highly consider, or that's an avenue I'd probably want to look down a little bit more. However, if it's partial, I wouldn't even think about going and having surgery until we go through a bout of conservative care, with also MRI scans when it happens or within the first weeks of it happening, and then a conservative route of anywhere from 2 to 6, 2 to 8 months of rehab with follow-ups of either MRI in between the rehab or at the end to look at, did the structures completely come together, or did they completely fully heal? If not, then I would look at kind of what Doc said, the PRP stem cell route, to see if we can accelerate the healing in that exact area. And if that still doesn't work or fully complete the healing stages, then I would possibly consider the surgical route. But it depends on how complete it was and if there are other structures involved.
Yeah, no, I know that's when always people are worried about that ending their career, but or at least their season. But more often than not, you'll find if you get someone who truly understands the knee and the body, they can return to play. You know, as long as they, like you said, compliance.
Yes.
You got to stick to that program, and it's intense and it's probably painful in the beginning. But it can be done. But I do agree, if they're in their prime, and it's such a crucial part of the stability of the knee, anchoring it might actually be better down the line.
Yeah, and if you want even more evidence, you can look to Edson et al. In 2010. They did a 10-week rehab of neuromuscular training in individuals with ACL injuries, and the injuries varied from complete to partial. There was intermittent results with that, but the patients that did not have complete had much more improvements in not only less pain, greater stability, improved range of motion, less guarding and tension around the area. So, which kind of backs our point on, with ACL injuries, it depends on complete, full, and other structures involved. Yeah.
And to touch on that, I had found this really, really good study that I think can help with, especially if you're an athlete. They took a look at those that did surgery right away, and then those who delayed surgery, again, if they wanted to try to finish their season. And what they found is, after 5 years, there was no difference in outcomes. So again, you have an ACL injury, and you believe you can get back to your sport with proper rehab, you don't have to worry so much about, should I get that surgery right now versus can I try to rehabilitate myself to finish the season? There isn't. What the research shows was you can actually delay that until the end of the season and get it later. There is no difference of outcome if you choose to delay it. So
that's a good point.
Yeah.
And with any injury itself, it's going to leave anatomical change to the structure, to where you're going to have to constantly pay attention in a rehab that ACL, PCL injury for years on end, depending on what activities you want to do. But when we hear of knee injuries, whether it's ACL or other variations, whether it's osteoarthritis, a lot of times people think of knee braces. Now, I know there's a study here by Benin in 2017 that showed the benefits of ACL injuries with bracing improves the proprioception of these individuals, but you can only rely on the brace for so long before the tissues around it are relying on the brace. And then if those give out, usually the tissues on the inside and outside of the knee, then there's other injuries that can come from that. So bracing can help for a certain period of time, but I wouldn't necessarily look to rely on that. It's just one small aspect that I know people are going to be probably thinking of. Do I brace? Do I not brace?
It's a crutch.
Yeah.
It's a crutch. If you want to try to return to play sooner, you might be relying on that brace. But again, I definitely want to make sure that you return to play after doing the necessary rehabilitation. Don't force because like Doc said, first comes the ACL, next might be the meniscus, might be the MCL.
Yes.
So if you didn't properly stabilize that area before returning to play, you're now putting yourself at a chance of injuring other tissues or structures. And that's then going to only further push your recovery out. It may even change your performance over time if you have to injure more tissues.
Absolutely.
Unless you're Connor McDavid, of course.
Dude,
but
that's going to be something. Man.
We're going to get to that soon.
That's crazy.
Another injury that can happen, Doc, is like we kind of moving down the line, like we said, first comes ACL, might come MCL, but then might come meniscus.
Yes.
So when a patient injures their meniscus, what are some pretty key symptoms that patients deal with when they injured their meniscus, and how does that present?
Yeah, it usually comes from lack of range of motion, like they're not able to fully bend their knee. They oftentimes comes with either swelling in the area, oftentimes in the inside portion, the medial portion. The more pressure on the inside can break down that cushion or the meniscus, and it leads to then degenerative changes or the injury itself. There could be pain with walking, and oftentimes it's hard for you to weight bear. You can find individuals have a limp. There's a whole bunch of different symptoms that can come from that, but
with the meniscus, a lot of people don't realize that it can also fray over time.
Good point.
And then eventually tear. It's not always something that's an acute tear. So when you start to develop the symptoms over time, you can sometimes have a confusion of is it arthritis, or is it actually a further deterioration of the joint and it's now getting to the meniscus. So just note that it's not something that only happens to those who received an acute injury. It can absolutely tear just over time. And if that does happen, just to make sure that you aren't putting off getting it looked at and assessed, because it can heavily deter you or prevent you from being fully mobile and doing the things day to day that you'll want to do. And when again, like we've talked about, the meniscus is cartilage, so it's not just going to get better. It's going to stay torn. There's really no coming back from it. There have been some cases of stem cells and repairing the meniscus, but sometimes it happens, sometimes it doesn't. So yes, there's technology out there trying to fully heal a meniscus that was torn without surgery, but again, we're still getting there. So if you get to that point where you can't overcome this meniscus issue, surgery might be something that you need to look at. But the only way you're going to know is to get it looked at. Meniscus issues are no joke. They are painful, and they are painful every day. You're going to have lack of motion. It's only going to also put further strain on the other areas of your body because you're just compensating with that pain too. So, but good news is I mean, it can absolutely be affected by a rehab, and we're going to get to that soon. So absolutely, we can impact it rehabilitatively. Doc, what are some things that you note when you see patients with meniscus injuries? How does that PT kind of look, and then what's the research behind it as well?
Yeah, well, if they have limitations fully bending their knee, we have to put stress on certain tissues gradually over time and less pressure off of others. So more or less that's going to involve more pressure on the outside for most people and less on the inside. It's also going to involve passive modalities. So whether that's person wearing an ankle weight on their foot and their leg dangles, and they try to go into that restriction with internal external rotation, which can help the glide of the femur or the top thigh bone slide on top of the meniscus. Also, if you get into rotational movements, whether it's turning your tibial inwards or outwards, that can also bring more blood flow to the edges, which can heal certain tissues depending on person to person, and depends on how well you can rehab that. So we have seen benefits of individuals coming back from meniscus tears to improve pain and to improve function, but I know from the patients we've seen, we did not do follow-up MRIs, so whether it fully heal the tear is tough for me to completely say. But I mean, there's even studies showing out there via physical therapy, and this is an RCT or randomized control trial by England et al. In 2013, which compared the effectiveness of physical therapy with arthroscopic partial mastectomy, which is pretty much a surgery that helps repair the menisci and those meniscal tears with degeneration. And they found that the study with both groups had similar improvements in pain function over a 12-month period of time, suggesting that PT can be as effective as surgery. I think this is patient dependent, and I think this depends on kind of like what Doc and I both have said, compliance with how well you do your movements and common positions that the individual find themselves in. Are they sitting for periods of time, or are they walking around? There's so many different factors with that, but
like I said on the last podcast, we had touched on how when someone tears their supraspinatus tendon, it's not always necessarily needed. There are things in our bodies that we can grow and rehab above the actual injury itself. So not to say that you maybe still have that injury or that lesion there, but your body can sometimes not recognize that it's there anymore, or even forget. As long as you're improving motion and strength and doing proper rehab, the pain will go down, and you might even regain full, if not all, function. Now, it's crazy to think that you have a torn something and you recovered fully. I know that can be a weird thing to think about, but that's just us trying to state how crazy our bodies are. We can absolutely retain or restore, if not close to 100% function after these really debilitating injuries. Now, to say that they fully healed or your tendon actually grew back and latched onto the bone, we're not saying that it can do that, especially even meniscus. But what we can note is, if you try to retrain and tell your body that, yes, you just had this injury, but I'm going to push through it, I'm going to make sure that I can try to restore motion, that pain will go down and your function will improve. So before we end, I want to bring up another study. This was done with what's called a sham surgery, which I love sham surgeries, because when you think about sham surgeries, it's kind of funny. What they do is they bring in a cohort of people that are actually going to get the study done, or the surgery done, and they're going to bring in people that they're going to trick into thinking they got the surgery. And when you think about this, you're like, how would I not know I got the surgery? Well, what they do is they make an incision on your leg to make it look like they cut you open and did surgery. Now, whether they actually went in and did anything, of course, you don't know that, because they're trying to randomize it. But those that did the actual surgery and those that did the sham surgery, what they found was that at 12 months, in terms of pain relief and function, there was no significant benefit over the actual surgery versus the sham surgery.
Power of the mind.
And so, exactly, the power of the mind. So you take a look at some of the statistics on meniscus surgery, which is not a favorite surgery of mine. The chance of needing knee replacement down the road after getting any meniscectomy surgery is about 25% more.
Wow.
So that increases 25%. The failure rate of meniscus surgery is about 1 in 5, 20%. So those, again, what we're saying is, what we're seeing is surgery isn't really ever necessarily needed in some of these cases. Not to say it's not needed in your case, but a lot of the times we can get above these injuries without surgery. And if you did choose to do surgery, it not only now creates change to that area, but it puts you at a further risk of needing other things down the road that I know just we don't want. So
Definitely not.
just wanted to touch on that.
No, that's perfect. Now, I know as we're getting into other structures, other conditions, injuries that are involved with the knee. I was thinking this morning, I brought this up to Doc before we started shooting today. I'm like, there's so many people that have Osgood Schlatters, which is pretty much a condition often found in younger folk going through puberty, to where the bone, the shin bone, right below the kneecap, starts to lead to fragmentation, or there's a fracture off of this tibial plateau, which then leads the individual not to go into weight-bearing activities, not to advance themselves in athletics, not able to explode through and build up muscle tissue.
Yep.
Doc, what is some information that you know about Osgood Schlatters?
I think the thing that you need to, especially if you're a parent watching this, looking out for your kids playing sports, the first thing they'll mention to you is, I got a bump on my shin, and it's painful.
Yes.
That's usually the first thing you'll note. So it's not something you want to just chalk up as, it could just be they fell and bumped it or something. Just get it looked at, because we'll throw up some x-rays of what it looks like. It can be quite severe. A quite severe change to your tibia, and you'll see the pictures, you'll know just that fragmentation Doc was talking about. It can be very intense and cause a lot of pains, and it can limit the performance of the athlete over time. So with Osgood Schlatters, I know one of the quickest ways to at least limit that pain is using what's called a Chopot strap, where you're just thin band around that. It can reduce the pain. It doesn't actually, again, take care of the fragmentation. That's unfortunately something that is going to be there unless you use surgical intervention. So
Good point.
over time, you're going to make sure that you can assess and appropriately train so that you're not having that extra pulling sensation of the patellar tendon, which again is causing the avulsion. Avulsion is just a word of this tendon or ligament pulling small parts of the bone off of the bone. Yes. And in all reality, it's a fracture. It's very painful. And if not assessed or even noted, it can go on to cause further damage. Some of the things that I know can take care of it really quickly. Laser therapy works phenomenal. Shockwave therapy works really great. If it gets to the point where those don't go well, back up PT.
Yeah,
I mean,
course.
again,
Yeah.
like I said, assessing quad dominance, making sure you're doing that. Exercise can take care of it too, but down the road, if you do need anything, laser is great, safe and easy. But PRP therapy at the end, even on kids younger than 18, it's very safe, can even take care of it in a very short course of injections. When I say take care of it, can limit it, even take care of the pain, and get rid of it for years.
That's beautiful.
So,
wow. I had no idea. I was
just
learning something new
things
too.
to note. Yeah. Doc,
good.
when you take a look at Osgood Schlatter, what's some of the first things you try to train or get the athlete to do differently?
Ooh, when I first look at that, I look at how well can that person dorsiflect, or pretty much bring their toes up to their body, and how well are the tissues on the bottom portion of the leg communicating to the knee, and is there excessive pulling? So I would first look to take x-rays of the knee with them in dorsiflexion, and is it pulling or causing more bone to slide off? If so, I'm gonna have to go other preventive measures, kind of like what Doc said. I would also want to see how well can the person go into a squat, how well can they do a lunge. I want to see also how are some of the limitations of how well your knees can go over your toes, and is there pain with that? Oftentimes there is, but to what degree? And then over time, we'd measure that via strengthening some of the tissues on the backside, the hamstrings. We'd want to do balanced proprioceptive work. We'd also want to do internal strengthening of the deep arch of the plantar fascia, or like the arch of your foot, if we will. All those to help support and better stabilize, less pressure off this tibial tuberosity, or where this fracture is occurring for them. And then also to see how well is the kneecap or patella, how well is that moving? Is it tracking properly? Is it compensating? If not, we do some muscle work and strengthening / mobility work to make sure that the kneecap is tracking properly. Thus, so we have less pressure and pulling tension on where the Osgood Schlatters would be.
I'm gonna put you on the spot because we haven't talked about this yet, but I'm excited to because we just got our backwards treadmill.
Ah, yeah.
Would you find that would be something to where it would help?
If the knee was built up over time to where if they walk, even if they go for a run and there's less pain, I would then start them on the backwards treadmill. But if they had severe pain, that would put a lot of pulling tension on the patellar tendon, which could cause the Osgood Schlatters to be worse, or more pulling of the bony fragments, if you will.
Got it. Wait, I just wanted to put that in.
No, that's good.
We do have a backwards treadmill in the clinic now, Doc. I know this is something that you've wanted forever, and I think, I don't even know how many clinics, even in Arizona, let alone the nation, have one of these. Pretty cutting edge piece of equipment. So obviously super important in making sure the knee tracks appropriately, but making sure you have good strength. When would we most typically use the backwards treadmill, and how does that improve the knee and, of course, other parts of the leg and hip?
Oh, I love that you brought that up. And this topic is kind of cool to go into. Shout out to ATG, which that's who we got it from. If you guys also have heard of Knee Over Toes guy, he created this product. I like it for a lot of different reasons. If you have problems in your whole posterior chain, whether that's feet problems, knee problems, even glute tightness or other conditions of the lower back, it can strengthen your whole posterior chain. So as we spend most of our time walking forwards, there could be gait imbalances. However, if we move in the opposite direction and push off on our heel, that will engage not only the quads, increase strengthening of the patellar tendon, improve the dorsiflexion of our bottom shin. It improves so many small things that not many people realize. And yes, you don't need a backwards treadmill. You can just go outside and walk backwards, and focusing on pushing off of your heel, and then go from toes, pushing off the heel, making sure that your feet are facing straight forward and not off to the side. That can do it as well. But when we got this therapy in, and I was definitely very excited about it, there's also patients that can improve from this. I think we're bringing healing and rehab to another level. And I know some of the staff obviously are definitely thrilled about this, because not only will it help our patients, but it'll also help our staff members who also need some rehab and training in that area. Shout out to them. But yeah, when I look at incorporating this into anyone's treatment plan, I see, okay, how well is the knee moving? Is the knee in pain? Is there stuff going on with gait problems? If so, I'm starting off making sure that they're moving into pain-free range of motion first, and then we're getting on to the treadmill and spending large amounts of time, starting off with 1 to 2 minutes of time. And this is a treadmill that you have to do the work. It's not electrically operated. So you're going to lean back and you're pushing pressure of your heels driving through the ground, which then strengthens the quads. It lengthens the hamstrings, which can help with tendonitis of also not only both sides of the hamstrings, but also even the calves, quads. So that's a huge aspect to where it can improve a lot of people's function. And I would highly suggest, if you don't have this backwards treadmill, transition from walking forward to walking backwards. Yes, you may look funny. I get stares all the time. I practice this on probably every 2 weeks or so, going for longer periods of time, walking backwards, getting lower, standing upright. It will only improve how well you can move and function, thus so you don't have more pressure on certain tissues or structures when you do walk forward over a period of time. But,
I just realized I don't remember the last time I walked backwards for more than 5 seconds. So again, what motions are you not doing often, and how you need to be training in them to make sure that you are, again, working those tissues that aren't usually worked over time more commonly. That makes a lot of sense. All right, let's get to the McDavid story. So for those of you who do not know, Connor McDavid, he's center for the Oilers, right?
Yep.
Yes, and Doc is going to go into, again, when I say this is one of the craziest injuries I've ever even heard of when it comes to a knee, it's incredible. And so, Doc, take it away on the McDavid injury. What happened? What was injured? And what was the outcome? And how he had to get through that? And yeah, I'll let you take it away.
Yeah, I was kind of thrilled to go into the knee for this body series for this story. So I've been following Connor McDavid ever since he was in the OHL Erie Otters when he was like 14, 15 years old. He is probably what you would consider one of the best hockey players in the world right now and over the last 5 years. So this has happened back in 2019, and there's a documentary on it. It's called Whatever It Takes, Connor McDavid. You can find that on Amazon Prime. It's only a few dollars, but I think if you have any idea how well the body can heal itself, this will give you so much more insight. And this is not just even the knee, but this can be related to many of the other structures throughout the whole body. So it all started with him, and he's one of the faster athletes. And not only is he fast, he also has the brain speed to think at a high pace. He also has the hand-eye coordination, the puck handling work, which makes him stand out much more than many of the other professional hockey players. But it started off against the Battle of Alberta, which is against the Calgary Flames and Oilers. Huge feud between those two. That may have played a part in this, but he was going down the outside. He then got tripped, went in to the post, hit his knee, and when it happened, that there was something definitely wrong. Even a few years before this, Steven Stamkos, another hockey player, ran into the post, and he had to spend a year and a half of just the rehab. He had surgery on his knee. So when they look back with Connor McDavid, initially in the interview, his first thoughts were, okay, am I going to need surgery? Is this going to impact my career long term? And he was early on in his career. What occurred was when they found out, they did MRI scanning, there was a bunch of fluid in the area, everything swelled up, and they thought it was just a partial tear of his PCL. They didn't think it was anything else. So they went to an orthopedic surgeon, the team doctor. They're saying, okay, it's ideal that you probably should have surgery or get multiple opinions. Okay, a week goes by, he's had an opinion from a specialist, and they said the same thing, probably surgery. It wasn't getting better. It was that point to where he's like, okay, I don't know if I want surgery. Is there anyone else? He then met up with Dr. Mark Lindsay. I think he's out of Colorado. He's a chiropractor. He also has a PhD. He's a soft tissue specialist. I idolize him because of this whole situation. So he said that I would suggest not having surgery. This is the route that I would go. And this is the route that Connor McDavid chose. And there was still a time of about 2 months, 1.5, 2 months, to where they were trying to see if they could rehab this injury without having surgery. But it all started on a few things. They found out as the time went on, he had a follow-up MRI, and it showed that he had a fully torn PCL, that's a ligament complete tear, a fully torn medial and lateral menisci. The meniscus were torn, frayed. He also had a complete tear of the Popliteus, which we know in the beginning controls locking and unlocking the knee. He also had a complete tear of the whole posterior capsule, which is the soft tissue on the whole back portion of the knee. And he also had a fracture on the tibial plateau, which is the shin bone on the very top. Oh. Now, all that being said, and to think of not having surgery is baffling to me. But to go into that, there was a couple main concerns they had. The main one was the PCL, and would those fibers attach? So what he did was every single day for 40 days straight, 2 hours of hyperbolic chamber. It's pretty much where it increases the oxygen of the whole body so you can accelerate the healing rate. When he was in the hyperbolic chamber, he was also doing light isometric contractions, which are contractions of his quads, 10 seconds on, 10 off, for 2 hours straight, every single day. And every week they took MRIs to see, did those tissues of the ligament where it was completely torn, they're looking for it to start to attach together. And roughly on the 40-day mark, they started noticing that the fibers started to come together. And that's where, on that specific part, on how the body can heal ligaments that are completely torn without any surgical operation, and how it can heal itself. Like that's it, that part baffled me. So once they started noticing that the fibers started to come together, they're like, okay, perfect, we can start loading this lightly in the pool. So what they did was they went into the pool, but they also added on another factor because they wanted about 5 to 10% of his body weight against gravity, so you can create the stiffness and recoil of that ligament. So that's where he had braces and almost flotation devices as he was in the pool. And he started off by just walking. He then, over time, as things got better and no problems, he started adding in small bounding movements, side to side, almost like A skips, B skips in the pool, just so you can get the tissues to communicate and the nervous system to communicate to the tissues. As time went on, as they took less of those flotation devices off of him and went straight on just body weight in the pool. So it just adds more pressure of his body against gravity on that specific tissue. Or you add on a couple weeks, then you start loading single leg bounding movements, side to side, forward and backwards. And then after that, he started adding in movement specialists. There's an individual, Lisa Scheckler, and she helped with core rotational movements, which as he was going through this rehab of not only the knee, they also wanted to focus on other areas of his game that they could improve on in core to extremity movements, whether it's turning, cutting, skating, stick handling. Core work works incredibly well to help stabilize and create the power and explosion to improve the athletic ability. So you add on a few more weeks of that. Then they started dry needling, they started myofascial release work, they started light contractions outside the pool of just building up the weights. As that went on, they added another gymnastics coach, Lawson Hammer, and that was for recreating the connection between the brain to those tissues, because as they were completely torn, that connection of those tissues that were torn to the brain, that had to reconnect. Yeah. So that's where the gymnastics and going through different movements of tumbling, of going into rotational work played into a factor. As time goes on, they also added in a figure skating coach, Tracy Wilson. She trains Olympian figure skaters to work on edge work as they're slowly starting to add him pressure against gravity and skating. Build on that, then over time he was able to skate. I remember there's a part in the documentary where he skated with his dad for the first time, and it was emotional, and it's weird, I'm tearing up at the same time watching this. Like I'm just like flabbergasted on how he went from not having surgery to now skating with all these fractures, with all these tears, with all these soft tissue injuries. And then he was ready to go by the start of the next season, which if you were to go to surgery, he would have probably been out for not only the start of the season, but also probably halfway through the season. And with metal in the knee, or if it was a complete replacement, it would probably limit his career and create all the complications. But where he's at right now, from that surgery to right now, he's set records in many different categories. He's still one of the best players thus far. So when we say the body can heal itself, that is a huge story that whenever I look to a person that has undergone a great deal of stress or injury, I immediately think of this story. Sometimes I don't bring up to that individual, but I know that the body can heal itself in many ways. It depends on how well compliant you are to the rehab. But like, he went from being a professional hockey player, working on hockey 24/7, to switching his focus completely to now he's a professional knee rehab candidate, to where all of his focus is on rehabbing this specific knee and the body so it can come together. So I think if that doesn't speak for itself, I don't know what else will. The whole rehab process took 179 days.
Half a year they turned him into a freaking work of art. Like, I don't know how. I'm curious if Lindsay was making stuff up on the way. Like, he's just probably like, I'm doing what I can, and this is going to be an experiment. But talk about
unreal.
Talk about knowing the body and just knowing the biomechanics of how things work, and just trying his best. And I mean, I'm sure McDavid was doing this full time. I'm sure how many hours a day he was. This was his job to get better. But regardless,
many hours.
Doesn't take away from the fact that that has to be one of the greatest comeback stories I've ever heard.
Yeah.
Like, phenomenal.
And even for that doctor to rely on other practitioners, other specialists, not that are even doctors, but others that can improve that person's function, I think is also something to be valued, that we should all take a lesson from, ourselves included. So
that's awesome. Thank you for that, Doc. That's super freaking cool, man. So, Doc, how can individuals at home start to work on their knee? Now, these individuals probably don't have the kind of knees that McDavid do, but what are some ways that they can assess their motion of their knee and other areas around the knee? What does that look like, and what does their homework look like?
Yeah, when you look at the knee, much the same with any other structure of the body through our body series, we want to see where the limitations are with your knee. So I suggest this to everyone, if you're in pain or not, if you are a professional athlete or not. This matters to how well you can connect consciously to the areas of either restriction or areas that you can improve on your body. So when we go at looking at the knee, we want to see what workspace we have available at that current moment. So what that involves is we want to move the joint through the biggest range of motion possible. So it involves us stabilizing the femur. We can focus on twisting or turning our ankle inwards, start to bend the knee as much as you possibly can, turn the ankle outwards, and then straighten again. Okay, both directions. You might notice there's going to be some guarding tightness and limitations of you turning your foot inwards and bending. And that all comes with overlying muscle guarding factors, but much the same with last week when we went into levels 1 through 3. Level 1 is moving nice fluently through the fullest range of motion. Level 2 is spending as much time as you possibly can around that line of tightness. So to increase and improve the range of motion, to have less guarding, to improve more blood flow, and to pick up those areas of waste products around the edges of the knee joint, you want to spend as much time slowly as you possibly can around that line of tightness with your foot inwards, and you want to straighten the knee completely, turn out, and the same thing, you want to try to turn the bottom leg, your shin, as much as you possibly can to flexion extension. And then over time, let's give it a few weeks, we can add on weights, and then you can do the same thing to build up that knee joint. And that is how you train the joints of your knee. Now, that's just one aspect. We also want to look at what are tissues top down affecting the knee, and also what are the muscles and structures going from bottom up affecting the knee from the bottom portion. So that's where we can do a few things and to improve the quality of your knee joint long term. You have to move in multiple ranges of motion, forward and backwards in the sagittal plane, on the frontal plane side to side and the transverse plane with rotation. The rotation, that'll take place with a lot of the training of the joints, thus the workspace that I just went in. However, if we're going to train the areas of tissues bottom up or feet up, we want to work on dorsiflexion and plantar flexion. So whether it's you stand against the wall and you bring your toes up and back down to improve the strength of your shin bones. You can also do the same thing by turning your foot inwards, staying up against the wall, and bring your toes up and plant down. Same thing, turn your foot outwards, feet up, feet down for the tissues on the inside of the bottom portion of the shin. So that's going to affect bottom up. Now, how can we affect top down? And this is where I'll take a page off of knee over toes guy. He's rehabbed his knee from, I don't know if he had a surgery, but he's had problems, and now he can move and explode through any type of movement however he pleases, and that is by moving your knees over your toes. So I know, Doc, when we were growing up, we were taught never put your knee over your toes. It can cause injury, it can lead to problems. And I thought that all the way through, I almost want to say undergrad, definitely through high school, and it's led to problems in my lower back. But as time went on, as we see these stories, as I started bringing my knee over my toes and building that up, I've had less knee pain, I've had less lower back pain, I've had a past injury at college soccer to where I completely blew out my bursas in my whole left knee. It led to pitting edema all the way down. It limited how well I could function and my limitations later on in my career. But as I slowly built up that over time, it strengthens not only the quads, but also the patellar tendon, which goes from pretty much the quads to the kneecap, to even below the kneecap, down to the tibial tuberosity. So if you increase how well and how much pressure that tendon, those muscles can withstand, that's also going to build up pressure and tension from top down to the knee. So when we look at not only top down, bottom up, we also want to look at the sides. So that involves either like side lunges, that involves us crossing over and coming down in squats. How well can we load those tissues on the outside and inside the knees? Just slowly over time, starting with either body weight, if at all, or assisted against the wall, and then build up from there, either speed, resistance, weight on the shoulders, weight in the hands. There's so many variations, but know the concepts is important.
Yeah, I think one of the easiest tests you'll find, if you put your foot just about a fist's length away from the wall, and then you try and drive your knee, the goal is to actually have your knee touch the wall. And if you can't, it just shows the limitation in movement that you have. And like Doc was saying, when he actually trained to improve that movement and improve that range of motion, it changed everything for you, you said.
God.
And
Yes.
excuse me, over time, when I was in basketball, I injured my knee, and I had done that test for the first time. I think it was in chiropractic college, and I realized that my left knee and my right knee had way different outcomes on that test, and I didn't realize just how limited I was with my knee after that injury. My guess it was from that injury. And when I started to again train the Achilles, lengthening that and trying to improve the motion of that knee joint, again coming forward more, it drastically changed everything for me too. So it's crazy how you actually had that story, because I had a similar story, so that was super interesting. But yeah, alrighty, that was everything we had on the knee, guys. Thank you so much again for continuing to support and watch us. Please like, subscribe, and just share with anyone who you feel this could be a benefit to. We're excited to bring you guys more and more pieces of content, so please just comment with what you guys are more interested in hearing about, and we would love to help in any way we can. So that is the knee. Guys, we'll see you next time. Doc?
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the functional code. Until next time, stay well, stay informed, and embrace the science of living well.